If you remember, back in July of 2012, we launched this episode, so we've had a lot of reports and a lot of things come down the pike since then, so we're just going to kind of review a little bit. Between July and September of 2012, you received some historical reports. This showed your performance during this period, but it did not impact the payment during the period. Our first performance period is complete. The episodes that our period dates are October of 2012 through December of 2013, and so the service dates are during the same period. The second performance period is currently running. It is going to have performance period from January 1st, 2014 through December 31st, 2014. And the service dates for that performance period are January 2013 through December of 2014. And that may be a little confusing, but an example is, say the episode closed on February 15th of 2014. Since it's a year long, it opened February 15th of 2013. So we're looking at the close dates, and then we have to go back a year for the open dates. And so therefore, the third performance period will begin January 1st, 2015 to December 31st, 2015. We're going to the next slide. Some of the episode design elements are, some of this is going to be a little review for you. Some of it is some new information. Any ADHD treatment defined by a primary diagnosis of the ICD-9 code, and we'll look at those codes in just a moment, with the exception of the initial assessment, is included in the episode, except if two or more claims with the same comorbid diagnosis are presented during that same episode period. The start of the episode, for new clients, the episode begins on the first date of treatment after a claim with an ADHD primary diagnosis. For recurring clients, the new episode starts on the date of first treatment after the previous episode ends, whether it be an office visit or therapy. The principal account provider, PCP, psychiatrist, or licensed clinical psychologist are eligible to be the PAP. Behavioral health provider organizations will be the official PAP when listed as a billing provider. If a licensed clinical psychologist treats a patient, a co-PAP is required, and providers share in the gain and risk sharing. After 60 days into a Level 1 episode, the PAP may submit a severity certification to qualify for Level 2 episode, terminating the Level 1 episode if necessary. Trish is going to go over the certifications in more depth a little later in the webinar. If the partial Level 1 episode is over 120 days, it will be counted toward the average episode cost on a prorated basis. If less than 120 days, it will be excluded. For the gain and risk sharing, you have acceptable, commendable, and gain-sharing limit thresholds that have been set based on historical practice patterns and guidelines, informed care requirements. PAPs may qualify for gain or risk sharing depending on the average cost across eligible episodes and completion of quality care metrics. An episode begins with the client's first billable treatment after presentation of a diagnosis of ADHD without comorbidities, defined by claims with primary diagnosis, ICD-9 codes matching ADHD, and some of those codes are below. The episode duration is 1 year unless the Level 1 episode is interrupted by a valid severity certification for Level 2 care. All medical services provided during the duration of the episode are included to calculate the episode cost for evaluation against cost thresholds. This includes all office visits, medication management, and psychotherapy, regardless of whether the care is guideline concordant. The assessment is excluded from the episode start date claims to encourage a complete and thorough diagnosis. However, if an assessment is done during the episode, then the cost will be included. All medications commonly prescribed for ADHD are included. Medicaid reimburses for the procedure codes recommended by evidence-based programs. The billing does not change. You still bill for the services. Below are an illustration of the therapy procedure codes that Medicare reimburses for today. If you'll note under the assessment testing, there are two new codes for the initial psychiatric diagnosis assessment and the mental health evaluation. That's your 90792 and 90791. ADHD episode is based on the current payable procedure codes. If more services are added in the future, average cost and thresholds will be adjusted accordingly. Now let's look at the principal account provider. Eligible to serve as a PAP are primary care physicians such as pediatricians, family practice physicians, psychiatrists, individual practice or within a behavioral health provider organization, licensed clinical psychologist in private individual practice. Now this does require a COPAP. PhD or PSYD training, licensed according to state requirements. A private practice psychologist would require a COPAP to write scripts. Behavioral health provider organizations, licensed clinical psychologist or psychiatrist. A behavioral health billing organization will be the principal account provider. The following are eligible to provide care but not to serve as a PAP. The APN, the licensed clinical social worker, school psychology specialist, other licensed mental health professionals, and mental health paraprofessionals within a behavioral health organization. Now, who is the attributed PAP? Physicians, psychiatrists, and licensed clinical psychologists are eligible to serve as the principal account provider. If only one PAP-eligible provider treats a client, that provider is automatically assigned as the PAP. If multiple PAP-eligible providers treat a client, the provider submitting the most claims will be assigned the PAP. However, if two potential PAPs have the same number of claims, then the provider with the highest spend will be assigned the PAP. If both PAPs also have the same spend, then the provider with the last date of service within the episode will be assigned the PAP. If a patient is treated by a licensed clinical psychologist, another PAP-eligible provider must serve as the co-PAP, and the gain in risk is shared among the co-PAPs. The next slide is just kind of a reference for you, kind of to see who would be assigned the PAP in different situations. For example, if you look at number 7, the PCP provided the most care for the patient. They were also seen by a psychiatrist or psychologist within an RSPMI. However, since the PCP provided the majority of the care, the PCP would be considered the principal account provider. And you can look through there and see which one may apply to your situation. And now I will turn it over to Dr. Miller.
So we're going to go through some of the slides that you've seen before, but this is a lot of it for a refresher. This first one talks about the clinical foundation and includes patients who are between the ages of 6 to 17 without behavioral health comorbid conditions. And you see over on the left-hand side, there's the treatment recommended in the specific guidelines and what's not indicated. Okay? And the guidelines are from the American Academy of Child and Adolescent Psychiatry and the American Academy of Pediatrics. So, and what's in that box is level 1 and level 2. So level 1, on the left-hand side, is ADHD with no behavioral health comorbid condition with a positive response to medication. And the treatment guidelines suggest 4 to 6 physician visits a year, medication, parent-teacher administered behavioral support, but they don't recommend psychosocial therapy, either in-office psychotherapy or group psychotherapy. Those are not part of the guidelines. For level 2, going back to the left-hand side, this again is ADHD with no behavioral health comorbid condition with a suboptimal response to medication. So for level 2, you get a few more visits with a physician per year, the same type of medication, you get the same parent-teacher administered behavioral support, but the difference here is you get some psychosocial therapy if needed. And that's all included in the episodes. What's not included is in the third box is ADHD with a behavioral health comorbid condition that constitute an exclusion. We go to the next slide, which sort of is a diagram of how it works, which I know you've all seen before. And so this is the design of the ADHD episode, which includes the 2 levels of severity with the required certification in partial episodes. So starting way over on the left, the client is diagnosed as ADHD. And remember that from my point of view, the assessment is really very important because that's what's going to trigger the diagnosis of ADHD or not. So the assessment is very important, and so important that it's not part of the episode. Then that triggers a quality assessment certification. And from there, we go into level 1 episode, which could be either partial or a full 365 days. And again, it's for ADHD only, no comorbid conditions, with a positive response to medication treatment in level 1. And again, here you see the treatment that's recommended. 4 to 6 physician visits a year, stimulant medication or other first-line medications, but preferably stimulants are really the first line. Parent-teacher behavior support. From there, you would go into a continuing care certification at the end of the year. If you follow the dots, you see the red box just to the left of it. The dots go back around, and you begin all over again. And that would be a continuing care certification. If you felt that level 1 wasn't working, and you heard Paula talk about the dates, after 60 days, before 120, you would then go into a severity certification if you wanted to try to go into a level 2 episode, which would be another 365-day episode. And it basically includes only ADHD, no comorbid conditions, and an inadequate response to medication or some other complication for the treatment in level 1. In the treatment, you get 6 visits with a physician, the same medication, either a stimulant or here a non-stimulant, parent-teacher behavior support, and the addition here is a psychosocial therapy. And again, after 365 days, you would need to do another continuing care certification and start that piece all over again. Okay. The next slide just shows the initial list of medication for which cost is counted against the overall episode cost. Basically, these are your stimulants and Strattera, which is a non-stimulant. Now, on this next slide, the important piece is over on the right-hand side. And we've normalized the drug cost to prevent providers from being biased to one drug or another on the basis of cost. Medicaid has a preferred drug list for stimulants, and we have a preferred list and those that are non-preferred. And so if you're and also for long-acting and short-acting. So if you are prescribing a preferred long-acting stimulant, and you look over here on the right side box in the bottom part, that talks about preferred long-acting stimulants. We've normalized the cost to $140 for the number of pills dispensed over 30 per month per medication. The actual cost of the medication is much more, and that's what the pharmacy would get. But for the basis of the episode, $140 is attributed for the cost for a long-acting preferred stimulant. Now, for a short-acting preferred stimulant, it would be $8 for the number of pills dispensed per 30 per month. So if it was only one pill per day, it would be $8. If it was two, it would be $16, and so forth. But these are for the long and short-acting preferred. For non-preferred medication, it's the actual cost. And there are some other things on the left-hand side that you can read, but I thought this was just a way of explaining about the attribution of the cost.